still some controversy about posture. But one possible way that some people are using is to put the babies in a prone position. Another posture that seems to help is a left lateral position. Put the baby on the left side. Studies have shown that putting the baby on the right side after a feed actually increases reflux. Dietary changes. Okay, sometimes if a baby is getting a formula, or if you're adding a lot of lipid to that baby's feeding, that can actually slow down gastric motility and increase gastroesophageal reflux. Just like in us, if we eat a meal that is very high in fat, we might have more gastroesophageal reflux. Same thing with babies. Thickened feedings, putting a little bit of rice cereal into the formula or with the breast milk. Or there are some formulas that actually will gel when you put them, when they hit the acid environment of the stomach, and that will actually help some in terms of having gastroesophageal reflux. Longer feeding infusions, taking a longer time to feed the baby. That sometimes helps because it strengthens, as Dr. Josef has shown, it strengthens the gastrointestinal emptying. And then sometimes transpyloric feedings can be helpful. You put a tube past the pylorus, and that certainly has been found to be helpful in certain situations. Next slide, please. Surgery, remember that most premature babies will outgrow their reflux and do not need surgery. There's only certain kinds of babies that really need to have surgery. These are the neurologically impaired infants that will require a gastrostomy. There are some babies who have life-threatening events that are related to regurgitation of feeds. Okay? And if you document that those life-threatening apneic events are related to those feeds using more sophisticated techniques than just looking at the baby, then certainly surgery should be taken into consideration. Failure to control with optimal medical management. And again, most GER in premature infants is transient. Okay, next slide. This is just the surgical treatment for gastroesophageal reflux. This is called a Nissen fundoplication. They take a part of the stomach, wrap it around the upper part of the esophagus, and that prevents reflux. Problem with this is that sometimes it's important to be able to vomit, and these individuals that have a Nissen fundoplication may not be able to vomit. So they lose that potentially important function. Next slide. Now, gastric emptying is another part of the physiology, and this is delayed in preterm infants compared to term infants. The rates are controlled by feedback from the small intestine. The factors that delay gastric emptying include fat, high glucose, acid, very high or very low osmolality, and increased caloric density. Sometimes if you give these extremely high caloric density formulas, 30 calorie per ounce formulas, those babies may not be able to empty that quite as well as a lower density formula. Next slide. Erythromycin is a drug that has been studied now for increasing gastric emptying. And there are at least 5 studies with different outcomes. It probably has a place in our treatment regimen, but probably also should not be used routinely. A fairly recent study that was reported not in the pediatric literature but in the gastroenterology literature, Dr. P.C. Ung from Hong Kong, from the Prince of Wales Hospital in Hong Kong, reported a very interesting study where they gave high-dose erythromycin to their babies, and it not only prevented it not only increased feeding tolerance, but also decreased cholestatic jaundice in these babies. But we don't know about long-term effects. We still don't know exactly the right dose to use. So the recommendation for erythromycin is you may want to use it in select babies that are having gastric emptying difficulties, but do not use it routinely at this time. we do not have enough evidence for routine use of erythromycin. Small intestine motor function. Now, when we think about motility and motor function of the gastrointestinal tract, we usually think of a nice pattern of motion of the food being propulsed down the gastrointestinal tract from the top of the small intestine to the bottom. Okay, premature babies don't do this. They have a very random type of movement. It doesn't go from the top to the bottom. Very random movement. And this is the absence of the mature motor responses. That's how it's elicited. And so these babies do not have normal motility, and food can stay in the gastrointestinal tract in the intestine for a long period of time because of this lack of the motility. So what this does, it causes a delay in the passage of meconium in infants, and it's delayed in about 20% of infants, less than 1,500 grams, and a study that was done in our hospital in the early 1990s showed that in some babies it's actually delayed up to 10 days in very low birth weight infants, those babies weighing less than 1,250 grams. Now, there are some ways that we can try to increase motility by giving certain kinds of drugs. I think that right now, giving drugs such as cisapride, the United States Food and Drug Administration has taken cisapride off the market, so we can't even use that. Okay, some people are advocating using routine enemas in babies to increase their intestinal evacuation. Some people are advocating this. I strongly recommend against doing routine enema or giving them glycerol suppositories. Okay, some people do advocate, but I recommend against that. There may be certain babies that you can give glycerol suppository or an enema to if they are having tremendous difficulty with stooling, if they have very hard stools, but this should not be done routinely, in my own opinion. Next slide, please. Now, digestion, absorption, and assimilation. 3 different words. Digestion occurs in the lumen of the intestine. Okay, right here. You have big proteins, big carbohydrates, big fats that have to be broken down into smaller components before they are absorbed by the microvillus membrane. So that's the next process, is absorption, which comes after digestion, and then after the absorption, it gets assimilated into the bloodstream. Okay, so 3 different words that actually mean different things. Frequently we use digestion and absorption as the same thing, but they really are somewhat different. Next slide. Now, in terms of protein, and I know that Dr. Ziegler and Dr. Thurine will be talking about this, this is something that certainly the fetus in the last trimester of pregnancy, studies that have been done by Dr. Ziegler and colleagues have shown that the fetus gets a tremendous amount of protein during that last trimester, about 3.5 to 4 grams per kilo per day of protein. Now, an extremely low birth weight infant would have to drink around 330 milliliters per kilo per day to meet this requirement. That's a lot more than these babies can tolerate. Next slide, please. So what I want to do is talk a little bit about the capability of the premature baby, a little bit about the physiology, and then talk about the strategies that we can use at minimal enteral nutrition to use the gastrointestinal tract. Well, in terms of the digestive processes, we have acid in the stomach. We have pancreatic and gastric proteases, which break down large proteins. We have lipases and amylases, which break down large lipids and large carbohydrates, respectively. In terms of gastric acid secretion, this is a study that was done in premature babies back in 1985 by Hyman and colleagues. And here you see the postnatal age as these babies get older in weeks, 1 week, 2 weeks, 3 weeks. Here is the acid output. And here you can see that this is the basal acid output, and this is if you stimulate the acid output with something called pentagastrin. You can see that the acid output in the first 3 weeks of life is actually fairly low. It goes up, but it's still fairly low. So the acid output in premature babies is not the same as it would be once they have reached a more mature level. Here you see it plateauing. Next slide, please. So from a clinical perspective, one of the things let me continue a little bit with some of the other physiologic situations here. We have proteases in the upper small intestine that are released by the pancreas in response to food. And this particular enzyme, enterokinase, is an activator of trypsinogen, and this causes this cascade of proteases to be released by the pancreas. Now, between 26 and 30 weeks, this enzyme is only 6%, and at term is 29% that of older children. Next slide, please. So this shows where enterokinase comes in, converting trypsinogen to trypsin, and that increases luminal protein digestion. And again, this enzyme is very low in the very low birth weight infant. Next slide, please. Now, what happens when we routinely use H2 blockers in premature babies? Do any of you use H2 blockers commonly in the babies? Raise your hand. Okay. Routinely? Okay. Okay. Now, there are many neonatal intensive care units that use H2 blockers in babies routinely. Well, fairly recently there's been some studies showing that these H2 blockers decrease acid output even more in the gastrointestinal tract. Remember, the gastric output is low to begin with. If you decrease that acid output even more, you can have some problems. Increased sepsis via the GI tract. One study now has shown increased necrotizing enterocolitis. And this is probably caused by an increased capability of certain microorganisms to pass the gastric barrier, and this will cause a higher intestinal load of certain kinds of potentially pathogenic bacteria. I put a question mark here because this is still hypothesis. We still don't know if that's the cause of increased NEC in babies who get these H2 blockers, but it has been seen. Next slide, please. Protein absorption. Now, after breakdown in the intestine, after digestion, the peptides are further hydrolyzed in the microvillus membrane. Some amino acids and oligopeptides are absorbed via the transporters, and some peptides that are absorbed intact are further hydrolyzed by enzymes that are actually inside the intestinal epithelial cell. And that's probably a process that involves more